All right, on to Chapter 7. So Chapter 7 is called Somatosensation Clinical Applications. So we talk a little bit about somatosensory testing, the functions of cessation, and then we go into pain and what we call anti-nociception systems or pain control systems. So really important stuff for physical therapy. Basically a continuation on what we talked about last quarter in modalities class. So lots of good basic information, and then we start to get more in depth with the pain management and pain control. It's a very interesting area. Being in physical therapy, of course, we are often dealing with people in pain. And how do we process that? How do we know what's going on with them? So sensation, somatosensation in particular, contributes to smooth, accurate movements by the adjustments made by the cerebellum, and prevention or minimization of injury, and our understanding of the external world. It tells us when to put on a sweater when we're cold. It tells us when to take our hand out of the fire. So this is important stuff. If we didn't have somatosensation, we would probably not live very long because we do not have that understanding of the external world. So somatosensory testing, as I said in Chapter 6, it covers the conscious relay pathways because you can't test something that you can't consciously perceive. So we're really covering the information carried in the conscious relay pathways to gain information to help localize a lesion. So that's why we do somatosensory testing in the clinic. We're trying to figure out where's the lesion, what's wrong, and then how we can address it. So somatosensory testing is, of course, limited by the reliance on conscious awareness of sensory stimulation. Even though other sensory information is going to other parts of the brain, all somatosensory testing requires that the patient has conscious awareness and cognition. So, in Chapter 7, Table 7.1 on pages 124 and 125, there is a really nifty little chart about all those different conscious sensory testing. And so these are the same things that we did in tests and measures last summer, but now we are going to explain it from a neurological point of view. What does it test? What is it? So, for example, we used a tuning fork to test vibration sense, and that's one of our conscious proprioception pathways. So, really, using a tuning fork to test vibration, it primarily tests the large A-beta peripheral nerve fibers and the dorsal column medial lemniscus neurons. So a lot of times if you have a lesion superior to the thalamus, it doesn't impair your vibration sensation. So if you have a stroke, for example, because that's superior to the thalamus, it happens in the cerebral cortex, you will still have vibration sense, which is important for movement sensation, that sort of thing. But if you had a lesion inferior to the thalamus, it might impair your vibration sensation because it's going to keep those vibration senses from getting to the thalamus. Okay, makes sense? So that table on page 7.1, you won't need to know all of the testing information for the exam, but it's a good reference, and you will be doing in neuro rehab class next quarter, you'll be doing more of this sensation testing. So I have the information here in the module, as well as on page 124 and 125 in Chapter 7. So you can look over that information. We do have one assignment this week where you pick one of those tests, and then you tell me which nerve pathways and types of nerves are being used to mediate that sensation. So basically we're trying to link up what we did last summer with the sensory testing to what we're learning now in clinical neurology. So a good way to get information solidified in your mind is to interleave it or interconnect it with information that you already know. So basically, having done the testing in lab last summer gives you a hook to hang the information on. And so now you can add another layer of information, as in what nerve pathways are involved in doing that individual testing. So that's our reason for reviewing this. I also have included little short videos. There may be about 30 seconds each on normal sensory testing for all these different things that are in the chart. So we're also going to talk a little bit about electrodiagnostic studies. Just to review, somatosensory sensations necessary for accurate control of movements and protects against injury. Sensory exams cover conscious relay pathways, that is, discriminative touch, conscious proprioception, fast pain, and discriminative temperature. And the purpose of the exam is to establish whether sensory impairment is present, and if so, the location, type of sensation affected, and the severity of the deficit. So we talked about these this summer, guidelines for improving the reliability of sensory testing. You want to administer the tests in a quiet, distraction-free setting. You want to position the patient seated or lying, supported by a firm, stable surface to avoid challenging balance. Because if your brain is busy trying to keep your balance, it is not going to be able to pay attention to these sensations. You want to explain the purpose of the test to the patient. You want to demonstrate each test before you administer it. You want to block the patient's vision during the test, because people don't cheat on purpose, but honestly, it's really easy to cheat. You want to apply the stimuli near the center of the dermatomes that are being tested. So, quick screening for testing for somatosensation includes testing proprioception and vibration in the fingers and toes, because those are the most distal portions. Testing fast pain sensations in the limbs, trunk, and face with a pinprick. So you want to be careful that you use a sterile tip and you're not hurting people when you're doing it. If loss or impairment of sensation is found with the quick screening, then that's when additional testing is done to determine the precise pattern of sensory loss. So, as PTAs, we're frequently not doing the initial testing. As a matter of fact, we're never doing the initial testing. The PT is doing it at the initial evaluation, or sometimes the neurologist at the you're reading their notes and you have the test for somatosensation. But we might be retesting later on in treatment, or we're testing sensation. Say the person got a new AFO, ankle foot orthosis brace for walking, and we're seeing if it's compressing in any spot, so we're testing sensation to make sure that the brace is fitted correctly. So even though it's not something, we don't do the primary testing, we often do retesting of these things, so it's something that PTAs need to know. That having been said, we can test and report our test results, but it's up to the PT to interpret the test results. That is not something we do as PTAs. So you can map patterns by comparing test results with maps of peripheral nerve distributions and dermatome distributions to determine whether there's a complete loss of sensation in a particular area. The patient has to have conscious awareness and cognition in order to accurately test somatosensation. So the tests don't test the ability to use somatosensation to prepare for movement or during movement, but they just test whether the sensation is there. Okay? So for the electrical activity from the nerves can reveal location of pathologic function. So the two methods used in electrodiagnostic studies for testing function are nerve conduction studies, which measures peripheral nerve function, and somatosensory evoked potentials, which test peripheral nerves and central nervous system pathways. So with nerve conduction studies, you're only testing peripheral nerve function, and somatosensory evoked potentials test CNS pathways. So the measurements that you get from these two studies can be compared with unaffected nerves in the same patient or with published normative values. So probably the most accurate thing is to compare it with unaffected nerves in the same patient. But there are also normal values, just like there are for a lot of things, and you can compare the results with that. So nerve conduction test, it's a surface recording with electrodes placed along the course of a peripheral nerve, and the nerve is electrically stimulated. So it only measures the performance of large diameter fibers, and it shows up as conduction velocity slowed if a nerve that has been demyelinated. So carpal tunnel syndrome, that's something that's commonly tested with nerve conduction studies. They're trying to locate the lesion. Is it in the carpal tunnel? Is it at the elbow? If you can have cubital tunnel syndrome, which is in the elbow. It could be at the shoulder, or it could be in the cervical spine. So basically, we're trying to locate where the lesion is. And then knowing that, we can tell what the treatment is going to be. So there are three numerical values that are compared to tell if a nerve conduction study is normal. One of them is distal latency, the amplitude of the evoked potential, and the conduction velocity. So basically, we don't, as PTs or PTAs don't perform nerve conduction studies. They're usually done at a specialty office, like a neurologist's office. But we can look at the information, compare them to norm, and see how that affects the individual patient we're working with. So somatosensory evoked potentials evaluate the function of the pathway from the periphery to the upper spinal cord or to the cerebral cortex. So the potentials are used to verify subtle signs and locate lesions of the dorsal roots, posterior columns, and brainstem. So you're not going to get any central nervous system information from nerve conduction studies, but you will get them from somatosensory evoked potentials. So mostly, that's mainly what I want you to know, is that nerve conduction studies evaluate the peripheral nervous system, and somatosensory evoked potentials do peripheral and central. So sensory ataxia, I talked a little bit about in the previous chapter. Ataxia is incoordination that is not the result of weakness. You can have incoordination that results from muscle weakness, but ataxia is incoordination that either results from sensory, vestibular, or cerebellar problems. There's a video in the module of the Romberg test, and it's used to distinguish between cerebellar ataxia and sensory ataxia. Basically, you're standing on one foot with your eyes open or your eyes closed. And if you have a big difference in balance with eyes open versus eyes closed, then you probably have sensory ataxia. So there's also one that's called the Sharp and Romberg, which delineates things a little bit better. So just know that ataxia can come from sensory issues, vestibular issues, or cerebellar issues. So the word neuropathy is really a general term. It just means dysfunction of one or more peripheral nerves. So it's a pretty vague term, but the severing of a peripheral nerve results in lack of sensation in that peripheral nerve distribution. You can have pain with the surrounding neurons, and sensory changes are often accompanied by motor and reflex loss. So you will hear a lot of times people say that, oh, I have peripheral neuropathy, or I have neuropathy, and it can result from diabetes, it can result from many other things, and it can be idiopathic, where it just comes on for no discernible reason. So people who have peripheral neuropathy in their feet, obviously it's going to affect their balance, because they're not getting that unconscious proprioceptive information to their cerebellum to be able to make those postural and movement adjustments. So people that have peripheral neuropathy are going to have trouble with balance, and a lot of times we're working on balance with people in the clinic who have peripheral neuropathy. And so what I usually say to people, I say, well, if you can't feel it with your feet, try to feel it with your knees. You know, I have them on a rocker board or an unstable surface. If you can't feel it with your knees, try to feel it with your hips. So take whatever information you have and try to use that to keep your balance. Sensory loss proceeds in a particular order. First, you lose conscious proprioception and discriminative touch. Then you lose cold sensation, then fast pain, then heat, then slow pain. So darn it, slow pain is the last to go. So you could have, your feet could be numb and still in pain, which is just not fair in any way. But there you go. So sensory loss kind of tends to go in that particular pathway. So there are some videos. One of them is from a neurology office describing what to expect with nerve conduction study and electromyogram, which is really kind of nice. You get an idea of, the patient gets an idea of what to expect. Somatosensory evoked potentials, sometimes they're used with someone in MS to localize a lesion, one of the sclerotic plaques that characterizes the disease. There's a little video on evoked potential testing in the module as well. So with the sensory abnormalities, you can get ataxia or incoordination. It's basically the lesion is somewhere along peripheral or central pathways. So people with sensory ataxia have better balance when their eyes are open, but they're usually unsteady with their eyes closed. Because they're, with their eyes open, they're able to use vision to compensate for decreased or lost somatosensory information. We'll talk about this in later chapters, but there are three main inputs to balance sensory inputs: vision, proprioception, and vestibular sense. And so if one of those is missing or impaired, you have to use the other ones to make up for that. When you test for conscious proprioception and vibratory sense, they can also distinguish between sensory ataxia and cerebellar ataxia. There's a video in the module demonstrating ataxic gait. It's sort of, it almost looks like someone's had a few too many drinks at the bar. That uncoordinated gait. It's usually a wide base of support, slightly staggering gait. You can watch the video and see that. It's something you might report in your objective section that someone has an ataxic gait. So peripheral nerve lesions, we talked about neuropathy. Spinal region lesions can cause various somatosensory symptoms depending on the injury. Brainstem regions cross the midline at various levels. So lesions in the brainstem can cause a mix of ipsilateral and contralateral signs depending on which tracts are involved. And cerebral lesions can usually cause contralateral somatosensory signs because the pathways cross over before they get to the cerebrum. So in the next section, we're going to start talking about pain.